Understanding Self-Harm and Suicide, Part 7. I'm Dr. Krisha Patel and I'm the mental health lead for the company. In this session, we're going to go through 3 scenarios that you may see in the SARC or police custody setting and think about the risk assessment and management plan for those scenarios. So here's the first scenario. You are the forensic nurse examiner working in the Sexual Assault Referral Centre, the SARC. You've just seen an 18-year-old girl who's attended the SARC following a rape. She has self-harmed once about 4 years ago following exam stress. So we're on to our aftercare assessment. And of course, we always assess self-harm risk for anyone who attends the SARC. So you've asked her about her past mental health history, her past self-harm history, when she last self-harmed. And the only thing she says is that 4 years ago, when she was 14 years old, she self-harmed with some superficial cuts to the wrist and immediately regretted it. She relates that to some exam stress. She didn't want to die at the time. And as she was only 14 at the time, you can think that between the ages of 14 and 18, she's developmentally matured in that time. She says that she has been feeling low following the rape. So this is our current mental state. We're trying to find out what her mood is like now and whether she has any self-harm, suicidal thoughts. She just says she feels low following the rape, but appears to be reactive to the situation. So of course, people will feel anxious or low or a mixture of emotions following something traumatic. There's nothing in the history to suggest this is clinical depression. So when it comes to clinical depression, the symptoms need to have been present for most days for at least a 2-week period. So that has to be low mood, low energy, loss of interest in things and other symptoms. They need to have been present for 2 weeks to make a diagnosis of clinical depression, and they have to have occurred on most days out of that 2-week period. But when you assess this young lady who's 18 years old, she tells you yesterday she was fine, she was seeing her friends, she went to college, she didn't have any low mood or anything. So that means there's nothing in the history at the moment to suggest she's clinically depressed. She may, of course, later develop clinical depression. So if she starts to feel low for several weeks following this incident, that may be clinical depression. But at this current time, it's not a clinical diagnosis of depression. You also explore suicidal thoughts and self-harm thoughts, and she denies any. So you've directly asked her, and she doesn't report any. She says no. She also says she's got supportive family and friends. She feels she can talk to her parents. She feels she can talk to her friends when there are problems. She's got close friends, and she thinks she can keep herself safe. What do you think is the risk of imminent self-harm? And what actions would you take as part of your safety plan for this young lady? I want you to pause the video and write down your thoughts. The framework that I generally like to think about when I'm doing suicide risk assessments is these 5 questions, which I've brought up in a previous webinar already. But make sure when you're thinking about your risk, don't automatically jump to an answer. Make sure you've thought about all of this. So 1, symptoms and signs of serious mental illness. 2, make sure you've considered the past mental health history, past self-harm history, and if there have been any recent suicidal attempts. 3, make sure you have explored their mental state, so what they are thinking right now when they're in front of you. Make sure you have asked about current suicidal thoughts, ideas, plans, or intent. 4, make sure you've considered risk factors and any protective factors. And only once you've considered 1, 2, 3, and 4, come up with an assessment in your clinical opinion of what you think the immediate or imminent risk of self-harm is, but also have in the back of your mind what the medium-term and long-term risks of self-harm are. Mostly when we are working in the SARC or in the police station, we are most concerned about the imminent risk of self-harm, because we want to know that when somebody is released from the police station or released from the SARC, that they are going to be safe and they're going to be safe at home or wherever they are released to. So I would put this 18-year-old lady into the low risk of self-harm category. So low risk of imminent self-harm based on what she's told me and her protective factors and risk factors and considering her mental health history. So pause the video and just look at this box here. Make sure you fully understand the sort of person who would fit into a low risk category. So the possible actions I would take now that I've done my assessment, considered her to be low risk, are to give her the phone numbers, so the phone numbers for rape crisis, and see if she wants a referral for counselling or to the independent sexual violence advocate. So there are many people who have self-harm thoughts or suicidal thoughts who will manage with the informal support of their family and friends and the support from emotional support lines like Rape Crisis or Samaritans. And they will never come to, they will never go to see a professional about that. So it will probably be the case that this young lady will manage with her friends and family to support her and the support services from the charities Rape Crisis and the counselling support as well. However, just because I've assessed her as being low risk at this time when she's in front of me, it doesn't mean that she won't deteriorate, and we need to give her a safety net plan and give her some advice of what to do if things deteriorate. So that's about making a crisis plan or a safety net plan with her, an individualized plan. So I'd talk to her and say, you know, if you feel your mental health is getting worse, who do you think you can talk to? Which family and friends do you reckon you can talk to, or who are you close to? And then I would say, you know, if things were getting worse still and you thought you needed some extra support, could you go see your GP? And then I'd also mention if it was out of hours and she felt like she couldn't wait until the next working day to see a GP, the other options that are available are to call NHS 111. You might want to find the local crisis line number for her local NHS mental health service. And also just let her know if she ever felt things were terrible and she really couldn't cope and she was worried about her safety or suicidal thoughts, she could always go to A&E, where there are a mental health team available 24/7 to assess people with mental health crisis. So let's move on to scenario 2. So now you are the healthcare practitioner working in police custody, and the sergeant has asked you to see someone who is about to be released because they're worried about his self-harm risk. And we're increasingly being asked to do that, to do fitness to release assessments on people who've been arrested for significant life-changing offences. So in this scenario, you're asked to see a 48-year-old male in custody who's been arrested following a significant child sexual assault. So arrested for a child sexual offence. This is clearly something that's life-changing. He has a past history of depression. So this is when you take your mental health history and your self-harm history, all he tells you is that he had depression 25 years ago whilst he was at university. He didn't seek professional help. It was self-diagnosed and self-managed, and he sort of came out of that. On your mental state examination, you notice that he looks low. He doesn't make much eye contact with you, so poor eye contact. He doesn't want to speak with you or engage with you, so the speech is not spontaneous. It's sort of yes/no answers, monosyllabic. And again, he doesn't want to engage. So when you try to explore and build rapport with him, it's difficult to build rapport. You try and explore their self-harm thoughts, or if he has any. All he says is, I don't know, I don't think so. He either doesn't have any thoughts or possibly some non-specific thoughts, or he may have some thoughts and is not telling us. But you can only go with the information he's telling you at the time. You've noticed there are some risk factors in the history. He lives alone. His job as a teacher is obviously suspended now following this offence. And there's nothing in the history to suggest clinical depression immediately before he was arrested. So he was managing well last week and the day before this arrest. He was eating, he's enjoying his job, enjoying life, and this happened. So it makes you think that this poor eye contact and this low mood seems to be reactive to this situation. And you've assessed him to have capacities, a mental capacity, to make his own decisions about his mental health. So what do you think is the risk of imminent self-harm for this 48-year-old male? And what actions would you take as part of your safety plan? Again, don't rush to an answer, but make sure you've thought about 1, 2, 3, 4 before coming up with your answer to the self-harm risk, which is based on your clinical opinion. So I've put him into the moderate risk category. There will be differences in opinion. So some people will think he's high risk, some people will say he's moderate to high risk. That's because there's no right or wrong answer. And when we do a self-harm risk assessment, we base it on the information in front of us, and it's based on our clinical experience, and it's subjective as well. So I'd like to, really pause this video and read this bit. This is the sort of rationale of why I thought he was moderate risk. And that's because he doesn't have a significant mental disorder present at the time I'm assessing him. He's not said any self-harm thoughts or plans or intent to act on his plans or anything to me right now. Of course, he may be hiding that and may be guarded and not be willing to tell me, but I can only go on the information he's telling me. And there are vulnerabilities present. So I've noticed I've picked up on those risk factors, being male, living alone, arrested for some life-changing offence, losing his job as well. So the possible actions I will take for this man who's moderate risk are to provide individualised support for him. So this charity, the Lucy Faithfull Foundation, is a charity that's very unique and works with offenders of child sexual offences and helps support families and the perpetrators as well. And they're very unique in that they are trying to prevent this awful crime from happening. And they do that by trying to work preventatively with the family and with the person. And obviously, when somebody is when somebody has committed an offence like this, they can feel very isolated, and being involved with the criminal justice system for a life-changing offence is a risk factor for self-harm and suicide on release. And of course, involve liaison and diversion teams if they're available in the daytime. They are able to support people on release for short periods of time as well. They can follow up people, they can call back people the following day to assess them. So they won't be able to do long-term management, but they can often support people for a short period of time when they're released from the police station. So see if the client wants to be referred to the liaison and diversion team if it's out of hours, so that you can give them the contact details the next day and ask liaison and diversion to follow them up. I would document a safety net plan for this man because there are risk factors and he is moderate risk of self-harm. So I would want to discuss and make that individualized safety net or crisis plan with him that explains what to do if things deteriorate. So I would ask him, I'd say, do you feel like you can talk to your friends and family about this? The answer to that may be no. So there's no point saying talk to your friends and family if he feels that he wouldn't be able to talk to them. I'd also mention Samaritans. I'd also say he could go to the GP if it's working hours, or using the out of hours phone lines for 111 and NHS crisis line, which is the mental health support crisis line. And again, go to A&E if you feel things were getting worse and he couldn't wait to be seen by the GP, or couldn't wait or didn't feel like he could keep himself safe overnight. And in general, doesn't necessarily mean in this case, but in general, if he was to consent, then you may want to inform the GP of what has happened and that he's at risk of deterioration in his mental health. If he's known to mental health services, you may want to alert them as well, or ask them to review him, or ask the client to see if he can attend for a review with his mental health team, like within a few days or a few weeks. So that's if they're known to a mental health service. Perhaps if they have a care coordinator because they have a serious mental health problem, then that would be an appropriate thing to do. Okay, so moving on to the final scenario now. So now, again, you're a healthcare practitioner in the police station. You are asked to assess a 20-year-old male who's been arrested following an assault on an emergency worker. So the circumstances of this arrest were that his friend called 999 after the client who you're seeing said he was going to kill himself and had locked himself in the bathroom. So the client says he's going to kill himself. He's locked himself in the bathroom. The friend calls 999, which seems like an appropriate thing to do. The police come, they knock down the door to the bathroom, and they've seen that the client has cut himself with a knife on his arms, his legs, and his neck. And that's clearly worrying if he's cut himself in the neck. It seems to be some quite deep wounds, as there's a lot of blood around him and on his arms and legs and neck. The police obviously want to keep the situation as safe as possible and want to remove any potential weapons. So they go to the client and they restrain him. They try to remove any sharp objects from him. During this restraint, the client says, "Don't come near me or I'll kill you," and hits out at one of the police officers. So he's resistive during the arrest and hits out at one of the police officers, which is why he's arrested. Quite rightly, the police see that he has some wounds around his neck, which appear a bit worrying, and they take him to A&E. They assess him, they clean his wounds. They notice that the wound around the neck is deep, but has thankfully not nicked any of the major arteries or veins around there. But it still needs suturing, so it's still deep enough to need some suturing around the neck. They suture the wound around the neck, they clean all the other wounds, give him a tetanus jab. They don't do a mental health assessment on him, even though this is a suicidal attempt. They just say, well, he's under police custody, so you can have one in the police station. And that's not good practice, because anyone who attends A&E should be treated the same. So it doesn't matter that he's under police custody. But as often happens, the A&E team deal with the physical health side of it, and they don't assess the mental health side of it. So that's when he comes to the police station. I come to assess him, and he tells me, when I'm taking a history from him, that he has a long history of mental health issues for years, even though he's only 20. He suffers from depression. There are some things that suggest emotionally unstable personality disorder, because there's a long history of self-harm, but it's not diagnosed, and that's often the case. There are substance misuse issues as well. He has a key worker and works with his drug and alcohol team, and he finds that key worker very useful. On his mental state examination, he says he's got ongoing suicidal intent. He had a desire to end his life when he cut his neck, and that desire is still there. He still wants to end his life. There have been lots of triggers recently, including homelessness. He feels absolutely hopeless about the future. There is no future for him. And he says, when I'm released, I'm just going to end my life. So what do you think is the risk of imminent self-harm for this man? And what actions would you take as part of your management plan or your safety plan for him? Again, work through these. Make sure you have considered point 1, 2, 3, and 4 before you come up with your self-harm risk assessment. So I think most people would agree that he is at high risk of imminent self-harm. Of course, there will be some differences in opinion, but based on what he's told me, he's got frank plans to engage in self-harming behavior, ongoing suicidal intent. There are serious mental health problems present and risk factors present. And it seems likely he'd act on those thoughts. There's a high risk that his mental state will deteriorate without intervention. He seems very vulnerable. So I think he's high risk of imminent self-harm, and I have to do something about that. It's my duty of care to make sure I've done the appropriate things for this gentleman to manage that risk. So the possible actions I've highlighted in bold. So I always need to consider the level of observations whilst he's in custody. So as a minimum, he needs to be on CCTV obs. So there needs to be somebody looking at him at all times on a TV screen. In this case, we actually chose level 4 obs, which was 2 police officers watching him to make sure nothing happened whilst he was in the cell. So wherever somebody is, if you have somebody who is high risk of self-harm, the same principle applies. You do not want to leave that person alone so that they can run away. You don't want to leave that person alone. So you want to make sure that there is a support worker with them or a family or friend with them. So I'm thinking he's high risk. I need to do something about it. Talk to liaison diversion team if they're present in the daytime. If they're not, I would call the crisis line, the NHS crisis line, because I want some background information here. And, if liaison diversion team are present, of course, they should assess him because he is high risk. But if they're not there, I still need some background information. What is his past mental health history? So the crisis line might be able to give you that information because they will have access to the notes, which you do not have in the police station. The person who's probably most useful in this situation for advice is the AMP, the Approved Mental Health Practitioner, and they're on call 24/7. They are the ones who organise a Mental Health Act assessment. They have access to the notes as well, so they can help guide you through whether they need a Mental Health Act assessment or not. They will organise the Mental Health Act assessment, and they will have access to the notes, which will be invaluable if you're not able to get a good history from the patient about their past psychiatric history. And of course, you can always call the on-call forensic medical examiner. Because I've considered this man to be at high risk of self-harm and suicide, I need to consider whether he needs a Mental Health Act assessment, either in the police station, or is it possible, if the police have finished the investigation and no longer require him to be detained under police custody, is it possible for him to be transferred on a Section 136 to the designated Section 136 suite, which is usually in a mental health unit? And then whilst he's there, he can be assessed. So whether it's more appropriate to have the Mental Health Act assessment in the police station or in the mental health unit will depend on what the police still have to do as part of their investigation. But if the client does not need to be detained in police custody any longer, the most appropriate place is going to be for a Mental Health Act assessment to be done in the designated Section 136 suite, which is usually in the local mental health unit. And of course, you want to document a good safety net plan on release if things deteriorate for anyone who you've considered to be high risk. The higher risk they are in terms of imminent self-harm, the better your documentation needs to be. Although in an ideal world, we'll do the best documentation for everyone we see. We know it's difficult because of time constraints, that's not always possible. But when you're thinking about someone who's moderate or high risk of self-harm and suicide, your documentation needs to be really good. So that takes us to the end of this session, and I just wanted to highlight the key points here. So completed suicide is uncommon. However, self-harm and suicidal thoughts are very common. It's really important to take the time to explore about suicidal thoughts. Suicide risk assessments are not accurate predictors of suicide, and that's not the reason we do them. We need to consider the history, the mental state examination findings, risk and protective factors when making a risk assessment of self-harm and suicide. And we need to do thorough risk assessments. We need to consider the client's problems and their psychosocial issues and their context. And then we need to think of an individualized safety net plan for anyone you think could be at risk. And that takes us to the end of the self-harm and suicide webinar series. I hope you've enjoyed this session and learnt a lot.